Another question I've been asked to cover is, how do I know where the centric position is within the philosophy that I'm looking at? Well, most of the patients that are coming to see me are already comfortable with a splint. It's one of the things I like before I start my therapy, is that they're wearing a splint and they're asymptomatic. And obviously the dentist or professional who's going to provide that splint will have looked into the centric position, determined that and worked on them. Although I've got 2 patients currently who didn't follow that process. One has walked straight in with problems and been successful, and the other had seen a specialist who then wasn't allowed to practice anymore, and the splint broke. She had already got symptoms before that. She'd stopped wearing the splint and was in pain when she saw me, and again, it's been very successful. It's only a study of 2, so it doesn't count for a lot. And the other point is that I don't actually really care where their centric is. If I'm going to change it, I know it's not correct, it's probably up and back. I don't really need to take an X-ray and expose them to any radiation to know that something's wrong. So we move forward and we aim to change where the centric position is. And it then makes me think about centric position in general and how it might be very, very important within temporomandibular dysfunction cases, and it clearly is, but it seems to be very unimportant in many other situations. One situation where it seems to be very unimportant is in jaw surgery. Mandibular surgery, where it affects the jaw. I did a lot of experience. I worked for some period as a junior surgeon, and usually my position was assisting the consultant surgeon who would do mandibular advancements, maxillary changes, and cancer and broken jaws and lots of extractions of difficult wisdom teeth. But in the complex surgery, I would be the assistant, and this was often a surgery to advance the mandible, and it's called a sagittal split mandibular advancement. The procedure would break the mandible on both sides, here and here. The mandible would be split with 2 overlapping sections, so it could be advanced, and then some screws would be placed through to hold those bits in place. And effectively, you'd advance the mandible on both sides. Now, every effort was made to make sure those 2 splits were pretty in line with the advancement you want to make, but it's impossible in surgery to get it correct. Inevitably, the angles would be offset in this direction, so that when you advanced the mandible and you screwed them back together again, the condyles would be in a completely different position. Also, we didn't use any location device to hold the condyles in position, and the location devices I've seen, I don't tend to find them or think they're very accurate. How we would hold the mandible in position is I would stand behind the patient, the anaesthetist would move to one side, and I would hold the mandible back in position, while the surgeon would then put the jaw into the surgical wafer. It's a little bit like a splint, but it's used to locate the teeth, so that the top jaw and bottom jaw then line up after the surgery, and we would screw it together. And I could not have been that accurate at holding them, not for like half an hour, 45 minutes, an hour of holding them in position. I'd have let slip at something. I know those surgical splints aren't that accurate. I know that as we screwed the screws in for the surgery, I would feel those back halves of the mandible moving across. You'd feel it moving across, so it clearly wasn't being screwed into exactly the right position. And of course, this is a tough operation. You're bound to get swelling within the jaw joint while you're doing that operation. And how can you make certain that the jaw joint is located correctly when you've got swelling going on? You know, it couldn't be correct. And yet, we've almost never had issues with jaw joint problems after surgery. We'd warn them before surgery, but we would have nerve problems, we would have bleeding, we would have pain. Sometimes the surgery went back or the screws got loose, but we never had jaw joint problems. But not when I was there. I mean, it has been recorded, but it's a rarity. And considering that nearly all of those condyles were placed in the wrong position, you know, out slightly, you know, why not? It was a broad group of people, from kids to adults. You'd have imagined some of them would have problems. Another quote, I quoted it in one of my previous presentations, but I didn't give the exact quote. It was Lund in '74, and the paper was a mandibular growth and the remodeling process after condylar fracture, a longitudinal cephalometric study, or encephalometric study. What Lund had postulated was that doctors in the emergency, the ER or the A&E rooms, same thing, concept, would frequently miss condylar fracture because they're not easy to see. You need a specialist to see that. He then went into a A&E department, or ER department, and he went back through historical records and he located a large volume of cases where they'd missed these fractures. And being in Denmark, or I think Sweden, where you can just process someone's number in and find out exactly everything about them and where they are now, he managed to get them all back again, or enough of them to study them. And what he found is that after many years, an amazing thing had happened. You would imagine that there would be a terrible problem, because of course when you fracture the condyle gets pulled away, the pterygoid muscles go into spasm and they pull the head of the condyle away completely. The condyle then resorbs and there's nothing left. But in 5% of these cases, there'd been terrible problems. They'd had infection and they'd had all kinds of problems within their jaw joints. In 50% of the cases, they'd actually had a complete regrowth of the jaw joint. The capsule had reformed, the pterygoid muscle had reinserted itself, it had formed a ligament into the back of the joint, it had formed a new a disc, the condyle was fine, the capsule was fine, everything was perfect except a little bit of extra growth so that the centroline had moved across in the opposite direction from where the original fracture was. And then in 45% of the cases, there was perfect growth. Absolutely everything was normal. So 95% of cases that were under 12 had completely normal growth, or recovery. They'd made a new condyle. And although over 12 is not as common, the literature is littered with individuals who have regrown their jaw joints. Even sometimes people who had had such bad temporomandibular dysfunction that it was electively removed. They'd taken the jaw joint out of a person to solve their jaw joint problems, and they had then regrown a completely new jaw joint, and everything could recover. And okay, they're only case studies, which means it's not everyone having that, but that seems amazing considering that that little difference between centric seems to be causing so much of a big problem. And when you're thinking about, is it important whether we find centric or not, seems to me less important when you consider that fact. Also, we consider when cranial osteopaths are manipulating skulls, they can manipulate skulls a lot. I've had it where my bite is completely out. Now, if they've done that, then they've moved all the bones of the skull. Now, they've moved all the bones of the skull, well, it will have completely changed the orientation of the condyle in its fossa. And if you've changed the orientation of the condyle in its fossa, you've yeah, you've changed your centric, at least in some orientations. And finally, I'm always interested in pathology, for the examples it can give us. And there are some very unfortunate individuals who will get a late onset muscular issue, who will have a bilateral stroke or neural damage, so that the whole face drops down and back. And when you look at the individuals, the whole of the skull changes shape. The frontal sphenoid angle, the saddle angle, changes. Of course, we can't really see the temporals on the x-rays we're taking, the lateral x-rays, but that's obviously changing as well. And all of these bones are changing, which must be changing the centric position. Now, they don't get jaw joint problems. It's not one of the things that they complain of or you see from pathology on. So, I don't actually think it's that important to locate the centric. I know in some areas it is going to be important, but in the type of approach, this out-of-the-box approach that we're looking at, it's not important, because we're going to remake the condyle in a new position. So I don't worry about centric.